And we have two dynamic speakers here today. Our first speaker for the day is Dr. URMI SHETH, who's a consultant in hematology working at Dinanath Mangeshkar Hospital as well as Ruby Hall Clinic, Pune. She's UK trained clinical hematologist with 9 years of experience, having MBBS and DNB medicine degrees from Mumbai, completed fellowship in hematology at Dinanath Mangeshkar Hospital in Pune, and obtained her diplomantship and fellowship in clinical hematology from the Royal College of Pathologists, London. Her clinical interests and expertise includes coagulation disorders, hematological malignancies, and hematopoietic stem cell transplants. So over to our first speaker, Dr. Urmi Sheth. Thank you.
Lovely. So at the outset, I would like to thank Kaho Diagnostic Division for giving me this opportunity. I'm going to talk about AML risk stratification. I'm only going to talk about how to stratify AML into different risk categories. Treatment based on these risk stratification will be beyond the scope of this lecture. So let's dive in. So why do we need to stratify AML? We know that AML is a heterogeneous disease. It has varied clinical outcomes. It's heterogeneous not only in terms of the ontogeny, but also in terms of its presentation, the age at which it presents, and its the biology and the ontogeny, as I said earlier. The treatment decisions rely on these initial risk categorizations, and therefore it is important to stratify the AML. At the outset, let's first basically divide AML into M3 and non-M3. We are going to talk only about non-M3 at the moment. M3 has its own most favorable risk stratification on the most favorable outcome, but we won't talk about that in this session. We're going to only talk about non-M3 AML. So the risk stratification is multi-layered. It incorporates not just cytogenetic molecular, but it incorporates the clinical, the cytogenetics molecular, and a newer parameter, which is the MRD. It incorporates all of these factors. This helps in the decision making for the treatment that is offered to these patients at the time of initiation, at different timestamps when the MRD is being done. And the treatment offered is in terms of chemotherapy, in terms of newer therapies which are available now, in terms of bone marrow transplant or targeted therapy. So what is the risk stratification framework? So the framework includes the clinical risk profile, which has patient-related risk factors, disease-related, and the disease ontogeny. Then we have a genetic risk factors. In this genetic profile, we have layers of cytogenetic, we have molecular recurrent rearrangements, we have aneuploidies, and we have gene mutations. Then comes the relatively newer parameter called a measurable or minimal residual disease, the MRD as we call it. There are different detection methods for this, and there are different timestamps at points at which this needs to be done to be able to give patient a better cure, a better chance at getting cured and treating the patient appropriately. Next are the new emerging biological risk factors. There are a host of them. We won't be discussing those today because I think it's beyond the scope of this chapter or this discussion. But I'll leave out some references if people are interested in going on and finding out further newer emerging biological risk factors. And then there are several scoring systems which are available, and there are there is a global risk assessment philosophy in AML which incorporates all of this knowledge, including the newer ones which are available, and then offers the patient the best treatment available. Let's go to the next slide, please. Yes. So like we said, the clinical risk factors are usually patient-related in terms of age, performance status, and frailty. As we can see here by the graph, which is shown that age is the strongest single predictor of overall survival. Patients who are more than 60 years have 5-year OS of less than 15%. Patients who are more than 70 years have outcomes which are even worse. Performance status is ECOG of more than or equal to 2 is strongly associated with inferior outcome. And there are certain markers called the frailty markers, which are NT-proBNP, albumin levels, interleukin-6 levels, the creat clearance levels, sarcopenia. and certain other scores, which tell us which give us an help us to gauge the outcome of the patient, which also helps us to understand the tolerability of the therapy that we are trying to provide to the patient. Having said that, there are certain markers are only the ones which are feasible and practical in doing, like albumin and the creat clearance. As a clinical practice, we don't do sarcopenias, and we refer to HSCT-CI for taking up patients before the transplant. Can we have the next slide, please? Right. So the disease-related risk factors are mainly 3 or 4. One of them is hyperleukocytosis, which is WBC of more than 50,000 to 1 lakh. This is the single most predictor of early death risk in the disease-related risk factors. Coagulopathy or DIC will suggest a high tumor burden and hence poorer outcome. Extramedullary disease, when present, always indicates a poor prognosis. And if the patient comes with a spontaneous tumor lysis or infection, this also is adds significantly to the morbidity and the mortality of the patient. So on a scale of 1 to 10, hyperleukocytosis slash leukostasis complicates the disease further, and it is significantly relatively confers a poor prognosis as against the other complications, disease-related complications. So now disease ontogeny, it also depends on how or whether the disease is primary or secondary or it is therapy related. It's a de novo AML if the patient has no prior hematologic disease, then yes, there is a certain level of favorable outcome which is expected as against the ones which progress from MDS or MPNs, and or the ones which come as a result of prior chemotherapy or radiation. We'll talk about all of these in detail. However, there is a paradigm shift in AML, as in the whole thing is now more about integrating the recurrent genetic or the molecular abnormalities, which we'll discuss as we go through the presentation further on. So if I had to fairly tell you how many were the de novo AML, about 60% of AMLs that we see are de novo. About 25% of them are secondary, and about 15% of them happen to be therapy related. Right. So this is an ELN 2022 stratification. It basically, I'll walk you through it. It's a busy slide, but bear with me. It essentially divides the disease into favorable, intermediate, and high risk. And this it does based on cytogenetics, which are seen. There are recurrent cytogenetic abnormalities or recurrent gene rearrangements, which are seen. Suffice to know that this colored box are all favorable. So when I say favorable, excluding the translocation 1517, which is PML-RARA, which is your M3, the other favorable risk factors which confer a better outcome or a prognosis to the patient are translocation 821, inversion 16, which is core binding factor. Then we have an NPM1 mutation. These are the ones which are favorable risk factors. So at the outset, when we diagnose a patient, we send off these markers. However, the turnaround time of these markers is anywhere between 7 days to 21 days, that is 1 week to 3 weeks. But based on these, we are deciding whether the patient, basically we stratify the patient, and we also try to offer the treatment accordingly to the patient. We'll digress this. We'll dissect this a little bit later once we go as on with the presentation. Can I have the next slide, please? Right. So it is saying that favorable risk factors are these recurrent gene rearrangement / mutations. There is a translocation 821, inversion 16, biallelic SEPA, NPM1 without FLT3 ITD. Intermediate risk is NPM1 present with FLT3 ITD. Normal karyotype with no adverse mutation is also kept in intermediate risk. And adverse risk is complex karyotype, TP53 mutation, and all these cytogenetic abnormalities, monosomy 5, deletion 5q, monosomy 7, and translocation 6-9, and so on and so forth. Can we have the next slide, please? Right. So from whatever that we've seen up till now, let's try to apply this to a case-based scenario, and let's see if we have understood that how we try to put a risk stratify a certain patient into a certain category. So elderly, TP53, complex karyotype, straight out and out high risk, because we said age was a high risk, TP53 mutated is also a high risk, complex karyotype also becomes a high risk. So in these patients, we consider a hypomethylating agent plus a venetoclax. If provided the patient gets into remission, if the patient is fit enough to go for surgery for a bone marrow transplant, then we offer them an allogenic stem cell transplant. TP53 mutated patients do not respond to intensive chemotherapy. So whether they are elderly or young, we must always consider a hypomethylating agent plus venetoclax. Now we have a young patient with a FLT3 ITD positive mutation. This patient is now kept into an intermediate category, and this FLT3 ITD inhibitor is introduced while in the induction itself, and the patient is then offered a transplant in CR1. NPM1 without any other, without a FLT3 ITD automatically forms into a favorable risk. On top of that, the MRD is also negative. So that also falls into a favorable risk. So these kind of patients do well with intensive chemotherapy. So we give them chemo consolidation. Can we have the next slide, please? Yes. So if I had to now, because we have hypomethylating agents and newer novel agents available, we can now look at the risk stratification from the point of view of as in we can amalgamate the presentation with the recurrent genetics and match them with what kind of therapy can we offer them so as to have a better outcome. So in the cohort of patients who I will offer intensive chemotherapy will be these patients who I know will do well or better with intensive chemotherapy, and I will risk stratify them into favorable, intermediate, or adverse depending on what therapy am I offering them. So for intensive chemotherapy, I will offer the AML with translocation 821, inversion 16, mutated NPM1, and SEPA with a BZIP in-frame mutated. Sorry, in the previous slide, I wrote biallelic SEPA, but that was a 2017 ELN guidelines. The newer guidelines do not consider the allelic bi or monoallelic SEPA. They just consider a BZIP in-frame mutation in SEPA to categorize it into a favorable risk factor. Can we have the next slide, please? Right. So this is a chart which is telling me that this group of patients will not do well with an intensive chemotherapy, and hence we have to think out of the box and offer them something which is known as hypomethylating agent plus venetoclax, and then eventually take them up for an autologous. Especially notorious to known is the mutated TP53, which will not work with intensive chemotherapy, and it has some chances of working better with a hypomethylating agent and a venetoclax combination. Can we have the next slide, please? Right. So let's now go on to the next layer of risk assessment, which is known as MRD, or it is also known as a measurable residual disease. So basically, what is measurable residual disease? What it means is that it is measuring the presence of the cells which are present after the treatment, even when the patient appears to be in a complete morphological remission. So over the period of time now, it has become the strongest post-remission predictor of relapse and a long-term survival in AML. What are the detection techniques that we use? We basically use three main modalities. Each has its own advantages and sensitivity levels. The first one that we use is a quantitative PCR. It is best for patients with stable molecular targets like NPM1 or RUNX1, RUNX1T1, or a core binding factor. Its sensitivity is 1 in 10 raised to 5 to 10 raised to 6 cells. Next one we have is a multi-parameter flow cytometry. This identifies immunophenotypes in more than 90% of the patients, and this is what is commonly being used. Sensitivity is 1 into 10 raised to 4. And then we, of course, have next generation sequencing, which is, deep profiling and especially for persistent mutations. Now, the question comes, when should we measure MRD? So the MRD is measured at multiple specific time points. There are 3 critical time points at which MRD is measured after induction to assess the depth of the initial response, after consolidation to determine the need for transplant, and pre and post transplant for predicting and preventing relapse. Uh, Now, does it have a prognostic marker? Why is it included in a risk stratification as a risk stratification parameter? Because yes, what is seen is that MRD negative patients have a higher overall survival of 68% at the end of 5 years versus MRD positive patients who have only 1/3 of those have an overall survival at the end of 5 years. And hence this dramatic difference therefore highlights the need for MRD to become central in AML treatment decisions. So it at the end, what I would, as in to conclude for MRD, I would like to say that it is not a static marker, it's an evolving dynamic marker, and it lets us refine the prognosis and and personalize the therapy in real time. Let's see how it does that. Can we have the next slide, please? So this is just a graphical presentation trying to tell you that MRD negative at the end of 5-year overall survival is close to 70% versus those who are MRD positive do not as well as the MRD negative ones. Can we have the next slide, please? Right. So yeah, so I think it's a repetitive slide. Can we do the next one, please? Right. So this is a tabulative form of trying to tell us which method is applicable, is best applicable, what are the timing of assessment, and how MRD-driven treatment decisions should be applied to each clinical case of AML that we see. These are embedded in ALN 2022. It's easily, freely available on the internet. Can we have the next one, please? Right. So let's now try to utilize the knowledge of MRD in some case scenarios. Let's discuss this gentleman. This was a 76-year-old AML patient. At the time of diagnosis, had a favorable cytogenetics, which had inversion 16 was favorable. And because of the age, uh, um, okay, this was complicated, but it was, sorry, let's start all over again. Sorry. So this was a 76-year-old male who was newly diagnosed AML. His cytogenetics came back as inversion 16. Because of his frailty, his age, we decided to, as in not so frail, but because of his age, we decided to treat him with hypomethylating agent and a venetoclax. A month later, his molecular markers came back showing that there is a core binding factor mutation which is positive, and there was a KIT mutation which was positive. Now, if we go back to the ALN stratification that we saw, the KIT mutation is a debatable mutation. We don't know if it definitely confers or reclassifies the favorable prognostic markers into intermediate or high risk because there are diverse or there are non-conforming or there are different outcomes in different studies. So we don't know, there are not, the results of different studies which included this KIT mutation is not the same. In some it has done well, in some it has not done well. So, it is still debatable. So looking at only the core binding factor, we then offered him consolidation, 5+2 induction, and these 3 cycles of HiDAC. He was diagnosed sometime in November, sometime in 2024, not November, sometime mid 2024 sort of a thing. In January 2025, he had his MRD positive. which was 8.57%. And that's when we did a bone marrow, which was 6 to 8% blasts. At that time, we offered him a mini FLAC chemotherapy. He went into morphologic remission, had MRD negativity, and because he was a fit 76-year-old elderly, we offered him a haploidentical TCR alpha beta depleted allo-HCT. The point I'm trying to make in this case is that a favorable risk AML can behave differently when KIT mutations are present. And that MRD assessment is key in knowing whether the patient is going to do well or patient is going to relapse. So at different time points doing the MRD at the end of 1 month, then at the end of 3rd month, then at the end of 6 months, this is going to tell us whether even though a favorable risk factor is present, the patient can relapse. Now, whether he relapsed with a KIT mutation or not is debatable. But the point to highlight is that even in a favorable prognosis, MRD becomes important to be monitored. Can we have the next slide, please? Right. So this I will walk you through this. This was a 36-year-old male who had a core binding factor AML, which is traditionally categorized as a favorable risk factor. Now he was 36, he had a favorable risk factor, so we treated him upfront with a 7+3 induction and 3 cycles of HiDAC. Went into morphologic remission. We kept on monitoring him with PCRs because it was an inversion 16. In February 2024, his quantitative PCR was done, which showed a low positive. The cycle threshold was 33. In April, it dropped to 27.98, which means there was a log increase in the transcript levels, and this now met the criteria of a molecular relapse. At the same time, we did a flow MRD, which also showed a positivity of 1.43%. We offered him then decitabine and venetoclax 1 cycle. Post cycle, he went into NRAS. He went into remission. The NRAS mutation became undetectable. We offered him a MUD allogenic stem cell transplant. So again, the same point to be highlighted that MRD monitoring is important, and closely observant and closely monitored MRD always helps in guiding the treatment further, because early molecular relapse is always actionable and it may warrant a transplant. Can I have the next slide, please? Yeah. So this was an interesting 16-year-old male. Out and out, he had a favorable disease. He had translocation 821. Because he was a pediatric patient, we offered him AML, BFM, went into morphologic remission. Early intensification became MRD negative, maintained that till, from May to September. However, in January, he relapsed. And at the time when he relapsed, he developed newer mutations, which was ETV6, NRAS, KIT mutations. So we gave him a salvage with FLAG. There was 75 to 80% of blasts still persist. We gave him AZA plus venetoclax plus dasatinib as a second salvage. There were 35 to 40% blasts still persistent. So we took him up upfront for an allo as HSCT despite active disease. So here we have not done any molecular monitoring post-relapse, but as of now, he has remained in remission. He's doing well. Here, important thing to find out is that there is a change in the disease biology. There are new acquired mutations, and hence a favorable risk factor at the time of relapse can become into a unfavorable risk factor. And again, highlighting the importance of MRD monitoring in these kind of cases. Can we have the next slide? Yes. So there are emerging tools and future directions. What are those? So there are gene expression signatures, 66 gene panels, 17 gene panels, and things like that. There is clonal hierarchy and dominance modeling, and AI is coming into a picture. There is a data or a World Bank which is created with all the mutations, recurrent cytogenetics, abnormalities, acquired chromosomal abnormalities, and all of those things. And that data or that knowledge is now in the future expected to become clinically available in the clinics while dispensing or devising treatment plans for these kind of patients. Can we have the next slide? Right. So can we have the next slide, please? Yeah. Okay. So if I had to summarize risk stratification when I see a patient of AML in my clinic, what will I do immediately? What will I do in the first week? And what am I expecting at the end of the month? In the first presentation, immediately, I will risk stratify him clinically based on his presentation, based on his performance status, comorbidities, age, disease-related criteria parameters that we already spoke about, and the disease ontogeny. I'll have some sense whether this is secondary AML, therapy-related AML, based on the clinical information that or the history that I find out from him. Within the first week, I will have a cytogenetics, which will show me any recurrent cytogenetic abnormalities which are present, which may confer or which may help me stratify him. It will also, at the end of the first month, it will give me an NGS panel, which will also tell me further help me stratify. And within the first week, I will not only just get karyotyping, but I will also get a FISH, which is available after treatment. After a complete remission is achieved, I will monitor MRD based on what recurrent mutations or cytogenetic abnormalities that I'm finding at the time of diagnosis. And we are hoping in the future there are certain novel biomarkers which will be available at the clinic level. There may be drug sensitivity levels and clonal architecture measurements and things like that. But that is all, at the moment, it's all in the clinical research. Can I have the next slide, please? Yes. So these are my references. Next slide, please. Yeah, so that was the end of how to clinically risk stratify newly diagnosed AML. I hope it has been, explanatory enough. And I'm happy to take questions at the end of the session, if there are any.
Yeah, thank you, Dr. Urmi. That was a very nice and crisp presentation, I can say.